So we had a week or two where things weren't up and running, but we're back. And this week we have Jessica Oswald, and she is a physician down at Hennepin Healthcare. She's going to be talking about HIV pre-exposure prophylaxis, something I don't think we've had this on before. If we have, it's been a long time ago. So happy to have her. We got some fun things coming up. And again, remember that we are going to every other week now, twice a week. Twice a month we are on. We pulled back a little bit after 6 or 7 years. So we're going to be doing it a little less often. So we got a lot of fun things coming up. You can peruse those. We don't get Charlie up until October. So yeah, he's a little ways out. I'm actually thinking about doing the August 28th. Yeah, but I'm going to keep that one a secret what it is. It's going to be kind of a fun talk.
And just remember that there is CME that's free offered with these sessions. And we love to see all your faces. So if you don't mind being on camera, it just makes it a little more interactive and fun. And we don't care if you're eating.
If any questions, please reach out. Our phone numbers are there. If you have some challenging questions, which reminds me, I've got to tell you about one errand that I got this morning. Got it. I was supposed to send it to you. And if there's anything that we can do, just please reach out. We're happy to help.
Stratus Health is the home for the core website, and that is very comprehensive to any policy, protocols, or tools that you may need in setting up a medication for opioid use disorder program within your healthcare organization.
All right. And so she was going to share hers. So again, today we are welcoming Dr. Jessica Oswald. We will let her introduce herself, tell us all about herself so we know every detail, and then we will let her get on with her talk. So thanks again for coming.
Yeah, I'm really happy to be here. It's my first time joining this ECHO. I am familiar with ECHO, though. I was part of the team that helped start what was the hepatitis C ECHO at Hennepin, and now is the Minnesota community collaboration for viral, or for things like viral hepatitis, maybe. But anyway, so I worked closely with Jesse Pell over time and think that ECHO is an awesome platform, and so happy to see so many of you tuned in. I'm an infectious disease doctor here at HCMC, and most of what I do is working in clinic for people living with HIV. So I have a busy clinical practice, saw patients all morning, we'll see patients all afternoon, where I also treat viral hepatitis, so hepatitis B and C. And I don't, in my clinical practice, do a lot of HIV prevention because as an ID doctor, I'm mostly caring for people once they get HIV. There are not enough ID doctors in the United States to be the prescribers of PrEP, which is why I'm so happy to give this talk, because PrEP should really be in the hands of other individuals in the community. It should not be reserved for infectious disease doctors. And so anything we can do to expand HIV PrEP prescribing to anyone who feels comfortable is where it should be done, like most things, like where patients are and in the providers or groups of people that they're seeing is where care should be. So happy to give this talk. As I'm talking, please feel free to stop me at any point. You don't need to wait to the end of the talk. So if you have a question or something's coming up, please feel free to chat or talk out loud. Or if Kurt or Aaron, if you guys see someone typing in, please stop me and let me know.
Absolutely.
Sounds good.
All right, I'll share my screen once I put it in.
In a way, Jessica, this is kind of like buprenorphine. We kind of feel like every clinic out in rural Minnesota should be doing it. And in a way, maybe everybody should be doing PrEP. You should just require everybody that comes on to start prescribing. So
let's see here. Not okay.
Perfect.
All right. And do you see it in presenter mode or do you see like the full screen?
It's full screens. Perfect.
Great. So going forward, when I say PrEP, just so that we're on the same page, this stands for pre-exposure prophylaxis, and I'm specifically referencing pre-exposure prophylaxis for HIV prevention. So if I say PrEP for this talk, assuming HIV pre-exposure, I have no relevant financial disclosures, and I am curious to learn on this call or who's joining in now, if anyone feels comfortable. If you are prescribing PrEP, like maybe raise your hand or type in the chat. are you prescribing PrEP? Or if you're not, and you're a prescriber or you're part of a practice and people aren't prescribing it, what are the barriers that you're coming onto in your places? Or any concerns or anything that you would need to help you prescribe PrEP?
Oddly, a little quiet in the chat.
If anyone feels comfortable, really unmute yourself, chime in. I'd love to hear.
Yeah, and maybe even if your clinic is doing PrEP, if you have PrEP prescribers.
Hi, I can share my very minimal experience. So I work in primary care in a family medicine clinic. I also work 1 day a week at urgent care. And I've done, Central Care is doing some broadening of their gender medicine to our primary care family medicine providers. And with that, I did a recent training on PrEP. And I'm trying to take it all in, but again, like anything, if you don't do it every day, it just feels like you kind of got to start from scratch every time you're presented with a potential. So I'll share that. 2 days ago, I was working urgent care and had a gentleman who asked me, he was in for dental pain and we were addressing that. And he asked me if I could prescribe it. And I took a beat and I said, yeah, probably, right? So he had been on it before. He had normal kidney function. He seemed really familiar. And so ultimately I did some up-to-dating, even though I should know what to do just to kind of check myself. And I prescribed him a small supply, but it felt kind of like very random. And I mean, I felt okay about it. I felt like it was the right choice. But yeah, I'd love to keep learning, even though I feel like I'm supposed to know. So in my everyday practice, I generally just am not often presented with the question, if that makes sense. Like with, my physicals and my standard 1,000 patients I take care of at the clinic. Very rarely do I get a question like I did the other day, but I tried to field it.
Yeah, that's awesome. Thank you so much for sharing that. Also, never feel bad about up-to-dating or looking something up. I think that's a sign of a good provider. I'm up-to-dating like constantly for things that I should know because it's great to double check yourself, reiterate that. So I love that. And I don't know that it's something a lot of people feel comfortable with. So I think what you're hearing, I've heard from a lot of people, is just we get comfortable doing the things we do, and we can only do so much, and we're asked to do a lot of things. So it's understandable.
Yeah. So just to give you a little more backstory on it, because it was kind of interesting. He had been living in a homeless shelter. Now he was living in a more consistent housing setup, but he was coming in contact with a lot of homeless people. I believe he was a homosexual man, but not currently in a relationship. He didn't really have an active concern. He had a previous partner who was HIV positive, but undetectable. So again, he knew more than me. And he wanted it. This was his context because he felt like he was often coming in contact with homeless individuals who had like open wounds, and he was helping them without gloves. And so he was trying to it was like prophylaxis, not because of sexual activity is how I understood it. I offered to do labs like twice and he didn't want to. Oh, go ahead. Uh-oh, did I lose you?
Nope. I'm just, I think that's great. And you're mentioning sort of a really good segue actually in talking about sort of like the objectives of what I'll cover is like, what are the indications? You're mentioning maybe this person felt they were at risk from body fluids, and we'll talk about what actually the indications are for PrEP, the efficacy, the importance of PrEP, and then we'll review some of the medication options. And then the main goal is to increase provider awareness or clinic awareness. So if you're maybe not a prescriber, but you work in a clinic, maybe you can help facilitate thinking about when a client or a patient might be a good candidate for PrEP and working with your prescribers in clinic. And I think that's a really important piece as well. So Gina, thank you so much for sharing that. If anyone else wants to share anything, I can pause for a moment as well.
Gina, thanks for being brave and sharing your story. That's awesome. Your patient was lucky to have you as a provider.
So I'll kind of dive in then. So what is PrEP? PrEP is medicine for people who are at risk for HIV to take for them to prevent getting HIV from sex or injection drug use, which are the most common ways that people get HIV. Sex and injection drug use, or sharing sometimes of works, but really injection use is the most common. The indications, and I bolded it, is anyone who asks for it. So Gina, like your patient who is asking for it, that is an indication, and the guidelines will go back to that again and again. So we talk about the more traditional indications. It's someone who maybe has a sexual partner with HIV, someone who's not consistently using condoms, diagnosed with a sexually transmitted infection in the last 6 months. If someone's injecting drugs with someone who has HIV, or sharing needles, syringes, or other equipment for injection drug use, those would all be classic indications for HIV PrEP. But the guidelines have realized that, like this and with Hep C screening and other things, that sometimes what patients tell us is what they feel comfortable telling us, and that's okay. But if someone's asking for PrEP, you might not understand, or they might not want to discuss all of their risk factors that they know or have. And so if someone's asking for PrEP, the correct answer is to offer them PrEP unless you have significant safety concerns around PrEP, which there are very few, and we'll talk about that later on. So up in the right-hand corner is PrEP versus PEP. So PrEP is what we're talking about today. This is before someone has an HIV exposure and before someone has HIV. PEP is if someone has an exposure. So if someone comes to clinic and they said they had an unfortunate situation where they were raped, or they shared needles inadvertently, or had a needle stick, or a sexual encounter that they weren't sure of the encounter, within 72 hours, you can give medications to prevent HIV, but that's PEP, and we won't talk about that in this, in covering this lecture today. Most of the information I have is founded on the guidelines. I'm not going to go, word for word by the guidelines, but these were updated in 2021. These are put out by the U.S. Public Health Service, and they're a really good resource. And this just sort of goes, there's two flow diagrams. One is for people who might have sexual risk factors, and the other one is for people who might have risk factors through injection drug use or substance use. And I took out the section here for injection drug use, as I thought that may or may not apply more to this group with people with co-occurring substance use disorders. So if someone's ever injected drugs, and even if the person in front of you says no, but they're requesting it, you prescribe PrEP. It's that simple. If they've injected in the past month or 6 months and they still say no, again, all of these things lead to prescribe if requested. Now, if someone is injecting and sharing injection equipment, I think it's really important then that we talk or start these conversations with patients. Whether or not the patient brings it forward, it's something that we should be bringing forward to patients. If they're injecting drugs and sharing equipment, we should bring that forward to patients and think about PrEP being a part of their treatment. So I asked this a little bit earlier. So I think most people are practicing or working in areas mostly outside of the metro, if that's correct. Is it mostly in Minnesota, or are there people on this call outside of Minnesota as well?
Mostly Minnesota.
Mostly Minnesota, and rural areas in Minnesota. And so, maybe you have encountered people at risk for HIV, or maybe you don't know if you've encountered people at risk for HIV. My guess is that you've encountered people who might be at risk for HIV. I bring this up because I practice in Minneapolis, and as you may or may not know, there's an HIV outbreak that's been ongoing over the last several years in Hennepin and Ramsey County, and also includes the Duluth area. So there's an increased clustering of cases in Hennepin, Ramsey County, Duluth area, mostly among people who are injecting drugs or sharing needles and works, people experiencing homelessness or unstable housing, men who have sex with men, and people who are exchanging sex for income or other needed items. So this is important because what happens in these metro areas, as people travel outside of these places. And so people are mobile and therefore infections are mobile. And so if there is an intersection, it's important to know this. So when it comes to PrEP, PrEP is really effective. For sexual transmission, if taken correctly, it's around 99% effective at preventing HIV infection. So it's not 100%, but it's darn near close. With injection drug use, we have a lot less information. Historically, studying people who inject drugs is just a harder population to capture and randomize clinical trials. And so we just don't have the same robust information about efficacy data, but it's reported to reduce risk by at least 74% when taken as prescribed.
I have a question for you, Jessica. So
Yeah.
if folks that inject, and if they did report as robustly as sexual transmission patients, do you think the efficacy would be relatively the same if reported as much as it should be? What's your thought on that?
Yeah, if like taken as often, I really don't know, because the transmission route, it would sort of depend. Because when it's sexual transmission, it's usually blood or semen amongst tissue where there's lymph tissue, and going directly vein to vein, it would sort of depend, like volume of blood on a hollow bore needle into a vein. And so sometimes I don't know the data behind it, but that's sometimes why the risk might be a little bit higher, because the highest rates of transmission would be like if someone got a blood transfusion from someone who had HIV, which we've been screening the blood pool since the 80s. So doesn't happen anymore. But that's why some of the risk effectiveness is maybe lower, but then again, difficult to study.
Okay, thank you.
Jessica, can I piggyback on that? Just another question. It's interesting because, and I think at Hennepin and other places, they've seen the same thing. We just don't see IV use as often as we used to because everybody's smoking fentanyl. Has that part of the transmission decreased at all? Because you say there's an outbreak. Is less of percentage of that outbreak related to IV use? At least in our areas, we're seeing less injectable.
That's interesting. So I am not in the field. I would say many of the cases I'm seeing, people are injecting.
Wow.
So I see it's a selective group, because oftentimes when I see people in the hospital, maybe with newly diagnosed HIV, I also see them for concurrent IV drug use related infections like endocarditis or osteomyelitis of their spine or other complications of injection drug use. And so I'm probably skewed in the population I see, but I see a lot of injection drug use.
Wow. Okay.
But again, I might be skewed and I don't know what the actual group is, which Dr. Resnikoff, whose office is one door down, would, have better guess that.
Okay, perfect. Thank you.
Any other questions? I will say though, Kurt, to that point though, we do know that there's a large crossover between risk factors and transmission. So people don't oftentimes nicely fit into buckets like exclusive sex risk or exclusive injection drug or substance use risk. Oftentimes there's overlap. So someone may be using drugs and then also having sex. And so whether they're injecting drugs or not injecting drugs, but if they're having sexual activity, there could be multi-modes of transmission risk, if that makes sense. So even if with fentanyl, someone's not injecting, but smoking frequently, maybe while high, they're having intercourse, or maybe they're having sex to obtain drugs or other necessary supplies or means. All right. So when I talk about the importance, we talked about the efficacy of PrEP, the importance, and I mentioned our current outbreak is that this is the ending the HIV epidemic in the US. And this was announced in 2019 with the goal of reducing new diagnosis of HIV by 90% by the year 2030. And it's to diagnose all people with HIV as early as possible so they can get on medications and undetectable. When people have undetectable viral load, they cannot transmit HIV sexually, we know that. So diagnose, treat, and then prevent. And so PrEP is a big and syringe service programs, which I'm sure many of you are familiar with, are really important interventions in this in these pillars to decrease rates of HIV in the United States. So that's why it's so important. And to stop our current outbreak is going to be diagnosing people who have HIV with HIV and getting them on meds, but then providing PrEP to people who are at risk for HIV infection. So what are these medications? There are 2 approved oral medications in the United States. They go by the brand names Truvada and Descovy. And Truvada, so these are the branded names. I, again, have no funding. Is generic and is tenofovir diproxil fumarate and emtricitabine. So there's actually 2 medications in Truvada, and there's 2 medications in Descovy. Truvada has been on the market the longest and has a significant amount of robust data behind it. It's approved for PrEP for all risk factors of HIV acquisition. So approved for people who have HIV risk through sex or injection drug use, for people with penises, for people with vaginas. And I say that specifically because the second medication, Descovy, obtained its approval in an MSM population and trans women population. So it was not studied with a risk factor of vaginal intercourse. And so we don't have efficacy data for people who have a risk factor through vaginal sex. It was also not studied in people who inject drugs. And so it doesn't have a recommendation in people who inject drugs. And so that's why I bring in those caveats. Those medications are HIV medications too, but they're not complete regimens. And that's an important thing to know. So when I'm seeing a person who has HIV, I would never use just one of these medications. That's an ineffective treatment for HIV. We need to add a more robust medication for treatment, but these medications are highly effective to prevent HIV infection. Most people tolerate these medications very well, and we have longstanding data on these medications. So the medications in Truvada have been used for a long time for HIV treatment, and I've had patients on them personally in my care since I was a fellow, so 7 years plus, and people do very well on medications long term. Side effects, though, can sometimes be those listed, like abdominal discomfort, headache, nausea, vomiting, diarrhea. Most of the times, if someone has symptoms, they abate over a week or so after the person's adjusted to taking the medication. Any questions about those 2 medications?
How about like drug interactions? Anything notable with that?
Great question. Very few drug interaction or drug-drug interactions. So no drug interactions with things like Suboxone, methadone, I don't know, other common medications that you all might use. If there's other ones,
maybe.
Mental health meds, generally not either. So there are generally very few drug-drug interactions.
That's awesome. Thank you.
Yeah, like very few I can think of off the top of my head. We'll talk about a little bit later, but yeah, I guess I'll talk about that next. There is an injection medication for PrEP called cabotegravir. The branded name is Apretude. This was approved a few years ago. It's very effective. It gained its approval for all people at risk via sex, but in the guidelines can be used for people who inject drugs if they are also at risk through sex. And so it does have an approval for people at risk through injection drug use, again, if also having sex. This medication, I have a lot of, it needs to take a pause because it's an amazing medication. It's a really exciting option because it's a once every 2-month injection that provides high protection against HIV. So that's incredible. So someone doesn't have to worry about taking the medication every day. They don't have to worry about losing their meds if they're in an unstable living environment, or getting their meds stolen if they're in a shelter or whatnot. It's great. It's an injection every 2 months, and it's very effective. The concerns are that it's not that after 2 months, the medication leaves a person's system, okay? So they found in women, they can find detectable levels of this medication up to a year or 2 after. But as you can imagine, when someone gets an injection, the level goes high in the body and then slowly comes down. The reason after 2 months you need another dose is to raise it up to an effective level. As this tail comes down, this medication stays in the body for, again, at least a year in men and women, and up to 2 years in women. The level comes low, and so someone's still at risk for HIV, but then if they were to get HIV, could have resistance to this medication. And this is in the same class of medications as some of our most effective HIV treatments. And so if someone develops resistance to this medication, all of a sudden they now have HIV, and they have HIV that's more challenging to treat and comes with more side effects, more pills, more drug-drug interactions. So treating their HIV becomes much more complicated.
Jessica, the obvious question then is, if this stays in the system that long, how about pregnancy?
Good question. So it was not studied in pregnant people, but as you can imagine, people have gotten pregnant while on it. There are no pregnancy concerns to date. There is an HIV treatment that has this medication and another medication in it for HIV treatment that's every 2 months. And we have had patients get pregnant on that medication. They're monitoring that, and there's no signals of safety data in or teratogenicity in pregnancy yet.
Some of the injectable forms of MOUD are way more costly than the oral ones. Is that the case with this too? And is it hard to get a prior auth for this? How does that look?
Yes. Yes, it is way more costly. And cost-effective analysis, this is not a cost-effective form of PrEP. It is very expensive. It does require prior authorizations by every insurance company I have tried. It will not always be approved. And then importantly, if it was to be used in a clinic, I would strongly suggest that you have like a robust team to track individuals to make sure they're getting their every 2-month injection. So this is something we do in our clinic. We have a dedicated injection nurse who her sole job is to make sure that patients are coming in every 2 months for their injectable treatments. And then we have someone, and so not that it has to be done that way, but it is important that people get every 2 months. So yes, there is the back end getting it approved. It is expensive. Like I think it's a couple $1,000s an injection, $2,000. Really great questions. There is also this on-demand PrEP, which is it's not in the guidelines from the US guidelines. So the CDC guidelines don't have on-demand PrEP as an option, but it is endorsed by the World Health Organization and the International AIDS Society for men who have sex with men or people who are at risk through rectal sex. So again, not in vaginal intercourse and not for substance use disorder risk factors. It's taken when you're at risk for sex. So I think, and it's only for Truvada, that first medication I talked about, that older, the first approved, it's only with Truvada. And so what happens is someone, let's say they know they're going to have sex on a Wednesday night. They can take 2 pills of the Truvada 2 to 24 hours before sex. They have sex, and they take 1 pill the 2 days afterwards. So I have some patients who know when they're going to have sex based on dates or events or thoughts. And so they'll take their 2 pills that day, and then daily, you take it daily if you continue to have sex daily. So if someone was on vacation or something having sex daily, they take the pill daily and for 2 days afterwards. And this is, again, only for people who are at risk via rectal sex, essentially, not vaginal sex, and not substance use or not injection drug use. People might choose this because it's less pill burden. If someone's paying out of pocket, you can imagine it's less medications, or if someone's only going to be having sex a couple times a year during certain events, they might not want to be on a pill every day, where it's mostly beneficial. It just wasn't studied in women, and so we don't have approvals for people with vaginas, but there likely will be more data out, and it doesn't mean that it couldn't be effective for someone with a vagina, but we don't have that data to support it. So thinking about this table is a little bit busy. This is from the International AIDS Society, and the link is, there's a hyperlink here in the PowerPoint that will go out to you. But the things to really think about before prescribing PrEP, there are a couple of main things. I would say 3 things that you should think about before prescribing PrEP. 1, do they have HIV? Because I mentioned that the medications for PrEP are not HIV treatment and should not be given to someone with HIV. So screen for HIV and ask about recent symptoms of HIV, which are generally viral symptoms. So rash, sore throat, fevers, headache. Do they have hepatitis B? That's a really important one because the medications in the oral pills for PrEP both treat hepatitis B. And if someone were to stop and then start them again, or stop and start, they can have a very significant hepatitis B flare that can even be fatal. And so important to check for hepatitis B status. The third is renal function. So if you were to check only 3 labs, it would be an HIV test, a hepatitis B test, and renal function. The renal function is that the older form of the original medication, Truvada, which is great, and it's still my first go-to for most people that I'm prescribing PrEP, is not recommended if someone has a GFR less than 60. Okay, I'm sorry, creatinine clearance less than 60. So creatinine clearance less than 60. It over time can be a bit hard on the bone and kidneys. And so if you have someone who also has osteoporosis, but that's a little bit more nuanced. The newer form of the medication called Descovy can be used down to creatinine clearance of 30. Okay. So when thinking about starting someone, make sure they don't have HIV, check if they have hepatitis B. If they do have hepatitis B, you might want to, if you don't feel comfortable managing hepatitis B, like maybe get involved with someone that would feel comfortable, because that can get a little nuanced, and then make sure their creatinine clearance is above 60. So this is where the CDC guidelines talk about HIV test, creatinine clearance, no contraindicated meds, which again, there are very, very few. And then you can start Truvada. And I would say you could start Truvada for most people. So all people at risk through injection use, sex can be given Truvada. It's recommended to follow up every 3 months to check for HIV every 3 months. And check for other STIs like gonorrhea, chlamydia, and syphilis if they're sexually active. And then every 6 to 12 months, checking their kidney function. And sort of outlines it all. So if this was something that you did feel comfortable and your client started prescribing, you could, cut this out or copy and paste and keep it next to your workstation, because we don't have to memorize things. We just need to know how to find the answers we need.
Jessica, is this an all or nothing thing where, let's say somebody gets side effects with it, can you go to a slightly lower dose to see if they tolerate it and get some benefit, or is it all or nothing?
It's all or nothing. So the Truvada is co-formulated at that dose, and so there's no dose adjustments recommended. So if someone takes Truvada and really is unable to tolerate it, even after an acclimation period, you could try switching to Descovy. Someone still can't tolerate that, would be an indication for the cabotegravir, or that injectable medication. Okay. But there's no dose adjustments. It's co-formulated, same doses.
And if this is a daily dose, have there been any studies done with it used every other day?
Yeah, they are studies looking into it. So with the Truvada, the only approved method is that on demand, like I talked about, but there's no studies to date that I'm aware of that look at like every other day dosing. But they are looking into that. Like there are studies in process, like minimum number of doses a week necessary to be effective.
Okay.
But at this point, I would not recommend that for people, or it would be off guidelines this time. For cabotegravir, again, this is a little bit different in that we don't worry about renal function. So that's another indication, is if someone had really poor renal function, the injection would be a good option. But it's super important that they get their injections every 2 months. And if they don't, or wanted to stop it and still had risk factors. So let's say someone's on the injection. I will tell you it hurts. So I warn all patients before starting, it hurts. It's a shot in the glute and it's a painful one. And it sometimes hurts for a day or two, but then it's, 2 months of protection. That after 2 months, if they're like, I don't want this shot again, and they're still at risk through injection drug use or sex, that they go on an alternative form for the next year and stay consistent with that, so that they go on a pill for the next year or eliminate their HIV risk because of that, like I said, that declining. Some just additional tidbits about a PrEP visit. If you were seeing someone, it reaches peak blood and rectal levels in 7 days. So if someone's just taking that one pill daily, I tell people for a week that that first week it doesn't reach full efficacy. And so maybe use backup protection, unless they were to do that loading dose of 2 pills. And it takes a bit longer in cervicovaginal tissue of 10 days. I mentioned screening for hepatitis B, and you can use that as an opportunity to vaccinate. It's recommended everybody be vaccinated for hepatitis B. And so take this as an opportunity. You should screen for hepatitis C in people on PrEP. And then you can also use these visits to offer other vaccines. I'm very biased as an ID doc, but I give everyone lots of vaccines. So hepatitis A, hepatitis B, tetanus, and HPV vaccines. So it is an all or nothing in meaning that it's like that dose, but it's not an all or nothing in like, this is not a cholesterol pill that we start people on and say you're going to be on this indefinitely. These are medications that we reevaluate risk factors. And so at every visit, I generally ask, how's it going? Do you feel like you still have ongoing risk factors? Do you want to continue PrEP? And most patients will say yes or no, and life's change, you know, so people can come on or off this. Like, no, I'm not having sex anymore. My life changed. I moved, I'm working more, or my use has changed. So I'm no longer injecting drugs. I'm only smoking. I'm using clean kits every time. You know, people can come on and off of these medications based on risk factors. Important to remember just that after 7 to 10 days of stopping, protection will wane. And if someone had hepatitis B, again, I'm just going to say one more time that that's a tenuous period. So if someone had hepatitis B and is going off oral PrEP and going on, they're then put this. Aaron had asked about insurance coverage for the injectable form. That can get a little tricky, but in general, the oral forms, especially Truvada, is covered by most insurance plans. I think I have it here. Like it should be covered by MA. It should be covered by commercial insurance plans. It should be covered by most insurance plans. And then there are other ways if someone still can't afford it with insurance, like copay cards, other programmings. And then if not, oftentimes if people don't have any form of insurance, you can get patient assistance programs. And then I guess most people are in Minnesota, so this doesn't really apply. But if people are eligible to receive care through the Indian Health Service, they should be able to get PrEP services through IHS. And veterans, so if people seek their care at VA services or VA facilities, they should be able to get PrEP there as well. And then I included a couple of short resources if people were interested. This is a 2-page document about like PrEP quick guide. So again, if this is something you're like, maybe I'm going to do this, try to do this more in clinic, and you just wanted to print something to have next to your desk, you could do that. And then there is the National Clinician Consultation Center that if you were seeing a patient for PrEP and you had a question, you can call and they provide free advice over the phone. And this is through UCSF, so it's entirely free. Any clinician can call. You don't have to have like a partnership or relationship with them. It's really incredible. And they also, on the NCC site, have this PrEP guide. So I hope we went over the indications. Are people who are at risk for HIV or anyone who asks for it. 99% effective through sex, at least 75-ish% through injection drug use, but that's an imperfect number. It's really important to prevent HIV infection and transmission and shut down our current outbreaks. There's 2 oral medications. I would say Truvada is generally the first go-to and has a lot of data behind its efficacy and use. And I hope I gave you some tools to maybe feel slightly more comfortable or know where to go if you were interested in prescribing PrEP. Because I do think it's important when we're thinking about the care of our patients. And I have some references here. And then I'm happy to take any questions or chat at all if people would like.
Yeah, I mean, if people want to unmute, you can sure unmute if you have questions. I know I still have a couple, but.
That was a great talk, super informative. Thank you so much.
You know, probably the biggest question would be how does MA handle this as far as paying for it prior auth? Is it difficult or is it generally pretty quick?
I don't know with Truvada, like doing generic Truvada, that I've had any issues with MA, and I've had patients be able to pick it up same day. Okay. So I just like have not heard much when I've been prescribing for patients.
Yeah. And it did seem like years ago, it was much more difficult to like write for. I mean, this is pretty easy now because you could put Truvada or generic, correct? And and it would just be taken care of. And it would just be more how you want them to take it. Is that correct? Yeah. And in general, like unless it's a man who has sex with men, it should be daily. Like if their risk factor is injection drug use,
it should be daily. And so, yeah, just generic Truvada daily.
Okay.
Do you find that patients are pretty open and using condoms frequently in addition to medications, or is it kind of a mixed bag and everyone's a little different?
I would say in my experience, condom use is inconsistent at best and infrequent in most situations. So we talk about safer sex because this prevents against HIV. It doesn't prevent against syphilis, gonorrhea, chlamydia, herpes. So we talk about condom use and provide them, but I would say a lot of patients are not using.
Sure.
There was a lot of, when PrEP really started rolling out, they're like, oh my gosh, this is going to increase the rates of STIs because people are going to use condoms less. And, with many of these things, like people are going to have sex if they're going to have sex, and they're going to have sex in the ways that they want to have sex. And so this is a harm reduction intervention, and it's an important one. And so.
All right. Other questions? Anybody else with any thoughts or questions?
Hi, this is Marlene Wood. I know you talked a little bit about pregnancy, but if a woman was on the PrEP and got pregnant, would there be harm to the baby, or do we just not know that yet?
Great question. These medications are safe in pregnancy. And so these medications are oftentimes part of medications we treat pregnant people who have HIV with. And so they are safe in pregnancy. And really great question, and super important to think about pregnant patients, because getting HIV in pregnancy is one of the highest risks that a baby would be born with HIV. And so if you can prevent HIV transmission in pregnancy, that's really important. So these medications, the oral medications, are known to be safe in pregnancy.
Thank you.
All right. Anyone else? Got another minute or two in case people have questions.
And Gina, I see your comment. Again, I'm so happy that you felt comfortable sharing that situation. You did what you could, and that was incredible. And you gave the person PrEP, and I think that's incredible. If they come back, you check labs then, and I don't think there's a lot of harm in that. I think the person asked for PrEP. I think you did the right thing and you prescribed PrEP. And when they come back, you'll get the labs.
And his was covered. I could see that it was PMAP, which would be a form of medical assistance, FYI. I mean, it was like a zero copay. So good news too on that regard, right?
Yeah, boy. All right. Well, I hope we have a lot more people that kind of consider this. I know I think that it's kind of, I had always looked at the barriers being just the pharmacy and the writing and the all this and that, but it doesn't appear like I was correct. So I think in my clinic, that's something we're going to talk about more. So thank you so much.
I see in the chat, Kat, any tips on getting cabotegravir approved? I often get PAs denied. Kat, I'm curious, when you're trying to get cabotegravir approved, have patients tried Truvada and Descovy and not tolerated them? Or is it just that people are wanting injectable? If you don't mind sharing a little bit more.
Not at all. No, this would be like a long-term patient on Truvada who wants to switch off the daily med.
And I would say I've had success mostly if I can document like any sort of worsening of renal function. I don't know how old, like if your person is like 40 or 50 or postmenopausal, then you can make the argument for the risks of osteoporosis or osteopenia. Or if they're not tolerating it, oftentimes I have to add those things into the PA and sort of add some of that into the request.
Have you had, I'm at Healthcare for the Homeless. Have you had luck in using social factors in prescribing, just because obviously injections can't be misplaced on a day-to-day?
I oftentimes will put that in there. I think the only concern that I'm seeing from like that I can anticipate coming up is that if the social factors, like if the person's regularly engaged in clinic, you can use that to their benefit, because they just want to say like, is the person going to not show up for their second, third, and fourth injections? And that can be problematic. But if you can say, this person has and routinely comes to clinic every month or however often they come, and they've lost medications on X, Y, and Z account. This is important for adherence. I think that would be a strong thing to put into the PA. A strong thesis to put in the PA.
There was a question from Christine Bell, and actually it was one I was just thinking after Gina was talking. Do you wait for the labs before you prescribe it, or do you figure if they get 1 or 2 doses and the creatinine comes back high, no big deal, just stop it?
I don't wait for the results because persons in clinic, our lab turnaround, I don't know y'all's lab turnaround, but for HIV combo test, hepatitis B and creatinine is oftentimes a day or 2. And so, yes, if they've gotten 1 or 2 doses, we can always shift course at that time if necessary. So generally don't wait for labs. The only time I would wait for labs is if you're really concerned they might have HIV, like they had a really high risk encounter 2 or 3 weeks ago, they have a viral illness, and you're thinking they might have acute HIV infection.
Okay, perfect. All right, anybody else? Boy, a lot of great questions today. All right, well, Jessica, I can't thank you enough. We may have to find you again about some of these other topics. This is a great talk. Really appreciate being able to pick your brain.
Yeah, thank you so much for having me, and thank you all for doing your amazing work everywhere. So important. So really appreciate you all.
All right, everybody, thanks for coming this week, and we will see you in 2 weeks. And anything comes up between, please don't be afraid to reach out. And thanks again, Jessica.